Dear Christoforos, thank you very much for your kind words. Ladies and gentlemen, dear organizing committee, thank you very much for the kind invitation. Tricuspid regurgitation is a growing problem that affects quite significant portion of the population. If we look at the general population, it's up to 65% if we assess any form of tricuspid severity. As we get older, this number is constantly increasing, and in the age group of 75 and above, it's essentially pretty similar to that of the aortic stenosis. The tricuspid valve disease has been more frequently diagnosed because of the impact of the intracardiac devices implantation and the increasing prevalence of atrial fibrillation. We know all these things, so I'm going to try to go as fast as possible. One of the most common things, as you already saw, is the problem that we have with the pacing leads. This led to the development of a research consortium as to how we define the tricuspid regurgitation, the trial endpoints, and how we manage. I strongly recommend this paper by hand that was published in JACC, and sums up all the current knowledge and all the knowledge gaps that we have as far as the tricuspid valve, what we know and where we go. The European and American guidelines are depicted here. If we look at the difference, the American ones, class 1 for severe TR at the time of left-sided surgery. The European is a little bit more, I think, concise. Severe symptomatic TS or asymptomatic at the time of left-sided valve surgery. Severe TR at the time of left-sided valve surgery. Symptomatic severe TR without severe RV dysfunction. Severe secondary TR at the time of surgery. This is the treatment algorithm if you have without concomitant left side valve surgery and with. The current classification, I think, is a little bit more helpful than the original one and than the anatomic one. And I think it's very important that we talk and we use this language since this novel calcification examines primary TR, secondary TR, atrial secondary, ventricular secondary, and CID. The TRI-score has revolutionized the way we talk and think about intervening for the tricuspid valve, and I think it's much better of a system. The more points you have, you see how the prognosis and the mortality changes. Risk factors: age greater than 70 years of age, class 3 or 4, right-sided heart failure, daily dose of furosemide greater than 125 milligrams at GFR less than 30, bilirubin, low EF, moderate to severe RV dysfunction. You can see the graph as how the mortality increases the more parameters you have. Papers have shown that the early surgery is associated with improved long-term survival. In one of these studies, and over the course of the years, the mortality of doing surgery for the tricuspid valve has significantly changed. Cardiologists sometimes say surgery for tricuspid valve has a mortality rate of close to 50%. That was decades ago, not anymore. Another study from a single US tertiary center, if you proceed with timely tricuspid valve surgery, the mortality is very low, and it does have impact on the survival. Video-assisted tricuspid valve surgery, first report 99. One more data on the endoscopic cases. This is a recent paper. What do we know about how we operate on these patients? Traditional sternotomy, minimally invasive, endoscopic. Those are all the studies that have been published. As you can see on the mortality rate, the mortality rate is not that bad anymore, with the exception of this study. It's single digit, 5, 7, 4, 4.6. So compared to what sometimes you read in the cardiology literature, it's not the same. For sure, the minimal invasive approach has had a quite significant impact on the mortality and the morbidity, and it looks like that the endoscopic might change things even better. We don't have any prospective randomized trial that has compared all these techniques, and for the most part is center-directed studies, and one of the, you just heard, one of the well-known surgical centers that does a lot of minimal invasive endoscopic tricuspid surgery with how good results they have. In our program over the past over 3 years, we have been employed with the endoscopic approach for all cardiac cases. At this point, we are over 380 cases. We had 2 conversions to sternotomy, 6 deaths. The older patient was 93 years old. The younger, we have been doing over the course of the time, smaller and smaller children. We're up to 12 kilos. This is our experience. 59 mitral repairs, 22 mitral replacements, 97 aortic, 11 cardiac tumors, 20 double valves, 11 tricuspid cases, 21 redos, and 138 congenital cases. Especially for the isolated tricuspid, out of those 11 cases, 9 were done beating. In 2 cases with intracardiac shunts, the cross-clamp tie was short. The ICU stay is relatively good for this kind of patient population, as well as the hospital stay. Decreased rate of transfusion, no mortality, 1 pacemaker implantation, 3 pleural effusions, and 1 leafron seal. We use the periareolar approach on the right and 2 accessory trocars for the stitches and the suction. This is one example of these cases. Can we play the video, please? Significant TID, significant TR secondary to CID. Next slide, please. Ευχαριστώ. This is the postoperative echo with trivial TR. This is the image 1 week postoperatively. And in conclusion, the endoscopic tricuspid valve repair is a demanding procedure but highly rewarding. It certainly requires a learning curve, and its length depends on personal adaptability of each surgeon to this relatively new technique. A high level of communication and group training is required for all the team members, including surgeons, anesthetists, perfusion, and nurses. It has to be mentioned that most of the criticism to minimal invasive has been overcome over the time due to the satisfactory results. The originally prolonged surgical times have been shown to significantly reduced, and morbidity and mortality is significantly reduced when combining the proper timing for surgical intervention with minimal invasive and especially endoscopic techniques. Thank you.
Thank you for this. So it is not a forgotten valve anymore.
It's never been for us. It's never been for us.
No.
I have a question. Congratulations on the talk, on the results. We know that edge-to-edge therapy is a class 2B indication in the European guidelines and not in the American guidelines. Do you have cases where you actually operate on secondary functional TRs when patients are very symptomatic?
Yes. Yes, we do. And having done these cases from traditional sternotomy to mini thoracotomy and endoscopic, I can tell you that the recovery period and the way that the patients go after surgery is dramatically better. So yes.
Any questions? If not, thank you very much, Dr. Mitropoulos.